Thank you very much for joining us today. I'm Ashley Johnson. I'm a risk management consultant at the STAR Group. So we're going to be talking today about health risk management. We're joined by Gavin from US Health Center. This topic is very near and dear to the STAR Group's heart and our mission for assisting our clients with being proactive versus reactive in healthcare. So this is going to be talking about healthcare, not sick care. The STAR Group is a team of self-funding experts. We have advanced certifications from the National Association of Health Underwriters in self-funding. We also believe in being a disruptor in the marketplace. US Health Center, we picked them as a trusted partner to join us today and talk about this topic because they, along with assisting our clients with risk management, they've also been able to assist the STAR Group with our own culture and well-being program as well, and have actually helped us reduce our total risk burden by 62%. So we are joined by Gavin. I also have Dan Kulak with me as well. He is another risk management consultant here at the STAR Group. Dan, if you want to say a quick hello.
Hello, everybody. Thank you for joining us this morning and giving up 30 to 35 minutes of your time to go through this great presentation that Gavin and US Health Center will be putting on for us.
Thanks so much for joining this morning. I'm honored to bring some information to everyone on the call. As Ashley mentioned, we have been working with STAR Group for over 13 years. I think this is our 13th year, and building a variety of risk management solutions. So it's been a journey. Everything I'm going to share with you today, we've been talking about and employing since our inception in 2003. To be frank with you, not too many of the slides have actually changed, other than getting a little bit more modernized. I personally have been involved in actually implementing programs in organizations that I've helped found, manufacturing, IT, those types of things before joining US Health Center in 2003 with my partner, Dr. Raymond Gaver. He was a medical doctor. Between the two of us, we've been working with hundreds and hundreds of organizations for quite a long time. Our mission here at US Health is to just do exactly what it says, improve people's health and reduce healthcare costs by providing industry-leading health management, science, technology, and advocacy to prevent and manage disease. I'll be talking about science, technology, and advocacy actually in that order. We also are firmly vetted and focused on personal predictive health. That is really what it's all about, is making it personalized. So just some stats. It says 8,000 employers. We actually have brought on about another 1,000 employers in 2020 so far. We work with thousands of physical locations throughout North America. We're fortunate to do business in Mexico. We have some overseas in Africa and Europe. We've got hundreds of different engagement plans designed, built, and managed. So whether you're an organization of just a couple hundred, or maybe in a group where you're in a captive of 50, or you're several thousand lives, everything that we do, from the people that are assigned to your population, the technology that's designed to help in the risk management, is all built to meet your particular needs, your subset of your populations. What you do in your home office is different than you do with your workers in the field, as an example. We work with, are integrated with many different types of organizations. One of the things that we like to point out is we have over 20,000 healthcare providers using the predicament plan. These are doctors, these are nurses that are on our solution, either as a caregiver, using it to deploy things like disease management for their own employees, or as an employee on a health plan that uses our solution as a component of its medical practice or medical program, their group health. I'll let you read some of the others. One of the things I'd like to point out is our average risk burden of 25% per group. We know that the average spend on a given health case is around $8,000 on average. Obviously, you've got your very expensive cases and your less expensive cases. Fortunate that we average 25% reduction of risk burden These are the potential spends that are coming down the pike. Ashley mentioned 60% for the STAR group. Lots of different clients. Some of you might notice in this marketplace, Ascension and Advocate Aurora, they license our solution in the Wisconsin marketplace. They bring it out to employers in different models, primarily technology, some screening, some coaching, those kinds of things. Also, all different kinds of health systems across the nation, different types of organizations, oil and gas, heavy manufacturing, retail, and a lot of clients that you may not know that we are actually the behind the scenes in companies that you would consider a competitor of ours. We consider our role in the marketplace as really the intel inside. How you use our chip to bring your solution to your population is really up to you. You want to go to the moon or you just want to tell time, we don't care. I'm not going to go over this particular slide. It'll be sent out, but this is an actual purchasing manager of a heavy oil and gas organization where, they built a program and she literally ended up, saying that we saved her life. And that showed up in the corporate report of this publicly held oil and gas company. It's kind of why we're here. So 4 things that organizations tell us that make us different. These are what our customers tell us. Our analytics, our ability to predict who's going to get sick with what disease, and then our ability to show you where your costs are. That's a lot of technology. Our ability to screen. We have our biggest clients in screening are sometimes organizations that are healthcare providers. They use our solutions to reach out and touch people across the nation. It brings a different flavor to the relationship with us, so it reduces the numbers of vendors that you need to work with. The technology is very broad and very deep, so anything from employee-facing portals to understanding what your costs are from a claims or pharmacy standpoint, of course, understanding what your future costs are going to be, to integrating with partners, points programs, reward mechanisms, communication. We do enrollment with licensed agents in the field. We do on-site clinics, really anything you can imagine that technology facilitates. And then our holistic coaching is an interesting way by which we reach the member, very similar to your primary care provider, one individual to talk to that handles all of your solutions, everything that you're dealing with, and if you need a referral to a specialist, but that coach is yours, and they work with you on whatever issues. So we're focused on really the entire continuum of care, whether it's the half of your population that's healthy or the 15% of your population that's currently creating the vast majority of your spend. But most importantly, in the area that's left out of the equation is who's going to be that next cancer, that next heart disease, that next high-risk pregnancy. Where are they? Who are they? How can we engage them? How can we get ahead of the curve? That's what we're built to do. The rest, frankly, is pretty easy. Standing up a walking challenge or dealing with a hospital discharge, we do those things as well. But dealing with the people that are going to be your cost, and you all know the numbers. Most people that are showing up in your claims this year never had any claim activity prior. Why is that? Well, it's because of what we're all after to prevent. Everyone shows up at the doctor when they're symptomatic. That's how providers get paid. So think of that. If you only took your car to the auto repair shop when it's broken, you're going to pay more money, and maybe you'll have to do something catastrophic. Maybe you won't have a car for a while. We seem to think that's okay, not only to treat our bodies that way, but also to get physicians compensated. So we're all about preventing disease and predicting it prior to the appearance of symptoms, and that requires what we call following the 4 Ps. Participatory is engaging the individual. In order to engage them, you have to make it about them. It has to be relatable to their particular point of view. In order to do that, you have to communicate to them about preventing something. It could be their first condition. It could be the worsening of an existing condition. It could be something completely unrelated that is going to impact their life. And of course, that means you need to predict that. And that's how we behave in a functional model. We have a 6-step process: identify risk, predict cost, manage what we know, that is going to result in better health outcomes, and that requires constant data analysis and ultimately lowering cost. I'm going to bring you through those quickly. It starts with understanding what is going to be our next cost. And so we have spent over 50 years, it says 25 years, it's actually twice that if you think about the intel, in understanding what causes disease, what causes colon cancer, what causes endometrial cancer, what causes heart disease, what causes depression, what causes back problems, etc. And once we know what causes it, by gathering all the data in what we call a synthesis analysis, using our AI, how do we synthesize the data that is out there in the various studies that are published in journals and so forth? So as a good example, think about heart disease. It's actually very predictable. We know the factors. It's been studied more than any other disease. But Cleveland Clinic and Mayo Clinic and Harvard and the CDC and the American Association of Family Physicians and the American Heart Association don't all agree on exactly what contributes and what weighting goes with which factors. So what we've done is synthesize that. No different than if you would ask a couple of attorneys and a couple of financial advisors about a serious decision you have to make, and you homogenize or synthesize the information. Now you've got a world view. And that's the trouble with most of the ways that we look at these predictive models. They don't consider synthesizing. And that's what we do. So now we know basically what data we need to collect from what silos. We can gather that data electronically through claims and pharmacy and demographic. We can go on site and gather the right kind of biometric data that contributes to the prediction of these diseases. And then we position that information in front of the member and gather the lifestyle data through the form of a health risk assessment. It creates two models, one that faces the member and one that faces the population manager. Now I could stop right there, and that's enough for everything, of what we do, and then we could carry on individual conversations. But let's talk about where it goes from there. So I'm happy to report that in 2014, after doing this for over a dozen years, there was a validation institute set up by the smart people at Intel and GE that said, okay, all you disease management and lifestyle and wellness people, prove to us that what you're doing works and makes sense. They looked at over 15,000 cases, asked us, how do we know whether our predictions are accurate? Which means that we had to go pull from our data and say, okay, we predicted that Billy Bob was going to get depression and Susie was going to get breast cancer and Frank was going to have a heart attack and Jill was going to have colon cancer. And unfortunately, the culture that was within their employer or their captive or their insurer didn't recognize that significantly enough, that they didn't find ways to engage the members significantly enough that they ended up getting that condition. And of course, contributing significantly to the cost and the quality of life. So those are failures. In order for us to calculate how good we are in predicting, we have to have those failures. In order to be able to have those failures, you have to have scads and scads of data. So they came out with this statement that we are 80 to 93% accurate in reducing ER visits and hospitalizations, meaning finding the condition and driving people to do something about it. That's a huge milestone in this industry. No one else has that statement. So we show to the member where their conditions are in the progression of disease for the conditions that are coming down the road. And it isn't, eating, drinking, smoking, exercise. Those kinds of things are contributory. It's that these particular conditions are erupting. And of course, that's what CFOs write checks for. That's what doctors write prescriptions for. And that's what people go home and tell their spouse or significant other that they've been diagnosed with something. Somebody doesn't go home and say, gee, the doctor told me that I've been diagnosed with obesity or smoking or stress. Those are things that contribute. That's the traditional problem why wellness doesn't work, is we focus on risk factors, not where the risk factors are leading. That's our general problem in our industry and why we're different. Now we know that what's going on here. Okay, can you still see my screen okay?
Nope, your screen just went away.
Yeah, I didn't touch anything. Let me just stick right here. Can you see it okay now?
We can see it.
Yeah, I know, I'm on the wrong slide. Let me check down to the right one.
Cool. Perfect. And it looks like you just need to get back to
So
presentation mode.
we are able to then predict the cost here, since we know what conditions are showing up. Oops, what's happening here? Having some technical difficulties with the screen share. Okay, we are able to understand the future costs since we know the conditions that are there. So where, the CDC will say obesity will cost you about $440 more, but obesity is just a portion of something like heart disease or certain cancers where body fat contributes to disease. And in this case, we know what conditions are out there. And so if we know what conditions are facing the population, should we not then also know what costs are facing the condition, since we know what things typically cost? So therefore, we ought to be able to predict not just how many cancers of what kind are in your population, but how much spend is there. And we know that we average about $8,000 a year per spend. Now you can see it's 8 to 10. We know the ranges. So we ought to be able to land at a number like that. I'm just going to skip a couple slides. This is an example of a risk burden report of pre-disease. These are the cases that are coming down the road. Okay, these are the people that are on your population right now that are within a statistical likelihood of becoming a claim in the next 3 years to a likelihood of 80 to 93%. And this is how much your risk burden is. In this case, this population is $4,900,000 of risk burden. About $1 million of it is male heart disease in these 40 cases. What's amazing to me is that our pre-disease risk burden range is right around that $8,000 spend. So not only do we know what the population is, of course we know who are these males and who are in these diabetics and who are in these breast cancers. We know who that is. So now we can engage them around conditions that are facing them. And now we're in a position of making a decision as to what are we going to do with this data. Many people might do things like a tobacco cessation program or a diabetes program. And I ask you the question, would you rather chase these 158 people around for a savings of $6,000 a year because somehow someone told you you have high glucose in your population? Or would you like to go to these 40 individuals and say, you know what, 15 of you have a risk for heart disease and our benefit plan is going to pay $100 for a heart scan to figure out which of those folks that are at risk are actually on the doorstep of a $100,000 problem. Completely different approach. It's really basic. In fact, all we say we're guilty of is automating common sense. Because if this was really your business, this is really what you would do. It's no different than any kind of audit. That's why I get confused about people getting confused, because it's very simple if you think about it in those terms. So, okay, now we know where our targets are. We've identified risk. Now we need to manage the population. Okay, that's good. It's good to know where to spend your effort. The most important thing is how are you going to do it? So we're going to start with understanding what's going on with your population. Our consultants will, just like your wellness team, we are wellness consultants. We have people with degrees in health and wellness management, most of them advanced degrees. They are people that have run wellness programs at very large organizations. They understand how to understand your population by knowing what incentives work, how you incent individuals, how you incent providers, how you do engagement activation, communication benchmarking. How do you communicate in your population? How do we get the word out? What have you done that you liked? What have you done that you don't like? What are you doing now that you'd like to do that isn't working? How do we put that all together? And then we'll build a plan that includes what data we might want to analyze, how we want to activate and engage members, and what kind of coaching program we might want to put in place. The coaching program is a very significant component of managing the predictable. You can't just throw a website out there and hope people behave. You can't throw a wellness challenge out there and hope people behave. You can't ask them to see your provider. This is not any different than any kind of cultural improvement. You have to have, like we say, the science, the technology, and the advocacy. This is the advocacy component. In our model, our holistic coach is an individual that is a registered nurse. They understand SPDs. They understand large claims. They understand how to communicate with insurance providers or insurance carriers. They also know how to understand how to communicate with medical providers. And they're going to be just like your primary care provider is the quarterback when you're getting care. This is your quarterback when you're not getting actual care, billable care. So we are in this situation where it's a triumvirate. They're working together, and you can read, what they do here. We also need to make sure that we're communicating. So we have all means of which we communicate via our app, via our newsletters, monthly. We can target specific things based on conditions in your population. There's all means by which we're going to reach out and touch individuals. I'm happy to say that we've also been recognized. We're the only organization in this industry that have been validated for care navigation. That's the ability to take individuals that we know are at risk and drive them through engagement so that they then ultimately reduce their risk. We won that last year in 2019. It was a new award, and it was pretty interesting. There's about 75 to 80 organizations that submit for this particular health value award. So we're going to work together with your population to build programs that are around particular conditions. For example, back injury prevention and musculoskeletal. How do we prevent these things that are debilitating? How do we work on preventing things like substance abuse and other kinds of mental health issues, opioid addiction and things of that nature? How do we work to help prevent things for cancers, coronary heart disease in this case, other metabolic conditions, diabetes, hypertension, things of that nature, stroke, etc. And then how do we work together to prevent cancers of all different kinds? Breast cancer is not colon cancer, is not endometrial cancer, is not prostate cancer. They're their own conditions. So it's important to point out that you need to really focus on those things and focus on those individuals that are at risk for these things. The next step in our process is, should we expect better health outcomes? And we're happy to report that we never really don't. If we focus on the conditions that are out there that are erupting, as opposed to organization that might focus on reducing biometrics. Well, let's just take that as an example. If you focus specifically on things like obesity or BMI, or you focus specifically on tobacco, or you focus specifically on other lifestyle categories, you will not be able to trace the reduction in cost. Simple case in point, if 15 to 25% of the population smokes, why is it that 0.06% of the individuals end up with lung cancer? And only 5% individuals end up with heart disease, which is certainly contributed to by tobacco, but less than a third of those individuals would have gotten heart disease because tobacco was the biggest contributor. So if you are focusing on a smoking cessation program that looks at all tobacco users, you're going to have a lot of wasted effort and a lot of false positives, and no way are you going to be able to trace your cost. So that's why you have to spend your time focusing on these conditions where all the risk factors contribute. This is a study we did internally, 4,600 individuals, 24 different unique customers, 2,000 cases, individuals were mitigated, 25% improvement, a total of $16 million, or there's that magic number, $8,000 per case. Now these are across all different things, very inexpensive conditions like diabetes and hypertension. These hardly cost you any cost on an individual case basis. And then expensive ones like heart disease and colon cancer and so forth. The next step in our process is concept data analysis. We have an incredibly giant tech stack. It starts with analyzing claims. If we have them, we don't need them. I don't want to, suggest that if you're not self-funded right now and you can't get access to your claims data, or you're smaller in nature according to the BUCAs, we don't need claims data, we don't need pharmacy data to do what we're doing. This is not using the past to predict the future. We don't need that data. We can do everything we want to do that I'm illustrating here in a completely self-reported health risk assessment. In fact, most of the information I'm sharing with you is based on that model alone, not even with biometric screenings. That's how interesting our model is. So that being said, we can gather data of all different kinds. We can generate the personal health dashboard. faces the member everything you want there, their medical claim information, all of their challenges, all of their points and steps, and Fitbit and Garmin and other types of integrations are there. Anything you want the member to possibly see about your benefit plan, links out to other sites, all of that stuff is all on their app, on their phone. We built that in 2003. So we've been doing that kind of portal, that kind of app work for over 15 years. The Coach Tracker is a solution that allows us to integrate, with various different organizations, and it's where everything from our case management, utilization review, claims-based disease management, lifestyle management, on-site coaching, on-site clinic, all of that activity occurs within that particular piece of technology. Health Counts is a tool set that is used for incentive design and tracking, reporting, reasonable alternative standards. It can integrate payroll, your health savings accounts or health reimbursement accounts. It does all your eligibility management. One thing that people don't necessarily understand in our industry here, we have to manage people that may not even have a relationship to the group medical plan. So a typical example, if the CEO's spouse wants to participate in a walking program because they want to earn a gift card, but they're not on the health plan, how do we track them? How do we engage them? We have to pay attention to all those kinds of things. That's what Health Counts does. Aggregate reporting, I'll show you some examples of that in a minute. So the next step is do we lower costs? Can we show a reduction in cost? And I can show you how that works. Here's a study that we did. Someone asked us to look at the last 4 years. Now this is about a year old now, so forgive the timing. But since 2015, we were able to illustrate that these many cases or lives saved were moved from a risk burden of getting this condition to one of a lower level where they aren't going to precipitate into a claim. Everything from skin cancer to stroke to lung cancer, etc. Everything really that you would normally see in a claims run. Here's some examples of some reporting. This is my favorite. I do realize it's somewhat difficult to read, but it lists the conditions on the bottom and then the risk burden by percentage of cases. And the blue is our benchmark. So you can see organizations that started well above our benchmark. Well above our benchmark and have now reduced to the point of being below the benchmark for everything from diabetes to depression to prostate cancer, heart disease, etc. This is actually cost. This is a group that we shared with STAR, where we tracked years of savings associated with that particular group and reducing both the repeat and the total spend of the population. This down here in the bottom left is the risk burden for the direct medical costs. And you can see if in this particular example went from 7,000 down to 4,700. And then we also track risk burden for productivity, absenteeism, presenteeism. Why are people missing work, or why are they going to work sick? And what is the contributing cost associated with that for what condition? So if you want to understand how to do a disease management program, you sure as heck aren't going to use the numbers to prove to you that you ought to buy that from Blue Cross for managing your diabetics and hypertensions and asthma and COPD. Clearly a waste of money, no traceability. But if you want to understand how to save money doing a flu program or a back injury prevention program on site, or something like measuring chronic headache, that's where you can save some absenteeism, presenteeism time. The data is very clear, but very few people have the data to look at. This is a good example of a coaching report, but as you can see, when we are looking at the holistic population here, this is where you're going to be able to see all of the things that are facing your population, from mental health and lifestyle-related activities like stress and anxiety to things that would typically end up in a large case type of management environment like colon cancer. And so all on one piece of paper, with one report, you're going to see where your people started in the diseases that they were facing, not having yet, but facing, that are about to come down the road and hit your claims, to how many did we pull off that pile, how much did we save per case, and you can look here how insanely conservative we are when it comes to saving per case. I don't think anybody on the phone would think that you're going to spend, $27,000 in a coronary heart disease case or 16 on a colon cancer. I can talk about that math at some other time, but just bear in mind that we're very conservative in our saving approaches. And yet we've reduced the risk burden by $339,000 here. So the question that we like to ask organizations is, when you ask the HR, the CFO, how are you doing with your population? How are you managing it? How are you understanding what your risk burden, what your costs are going to be down the road? You're typically going to have to find out from a half a dozen different vendors what's going on. Maybe you've got a screening vendor. Maybe you've got a coaching vendor. Maybe you've got a fitness vendor. Maybe you've got an EAP. Maybe you have a disease management vendor. Maybe you've got somebody doing large case management, utilization review. Well, are you going to aggregate all that data into one unified database and look at your population and say, how are we doing, and then be able to have traceability down to Bill and Sue and Frank? Highly unlikely. And that's the significance of looking at your population in the whole. I think that's really the ultimate, bottom line. So I'm happy to report that in 2020, we also were recognized by the Health Value Awards for population health management. That's a unique distinction where you combine the ability of analytics along with the ability to reduce risk and drive people through a lower risk burden. There were nearly 100 applicants. 67 organizations had enough data to make the cut. These are 30 different categories, okay? So there are certainly different things, but there's a lot of people in the care navigation world. That's kind of where we applied, but most of those were what we call one-trick ponies. They're just focusing on diabetes, or they're focusing on exercise, or they're focusing on, maybe stress or something along those lines. And you find yourself in a traditional employer population or employer purchase of buying all these specialists. And not only do you have crossover amongst individuals, because people aren't, a diabetic. They have a health risk of which diabetes might be a piece of their puzzle, but they probably also have things that are either coming down the road or going on in their past that they need to manage. So that's the whole idea. People aren't a disease. They're individuals that have conditions, lifestyles, and medical conditions. We're all going to get something, right? I mean, that's the thing we can't run away from. We're all going to have something. So what is that thing that we're going to have, and how can we do our best to slow it down or prevent it? That's what we're all about. So that's kind of my spiel, and super happy to participate. Really appreciate Dan and Ashley, Greg, Tim, Paul, the folks that we work with at STAR to help us bring our message to the market. And I hope this was beneficial, and I've got some time to answer questions.
All right, Gavin, thank you so much for your time today. This was a great presentation. Does anybody have any questions for Gavin before he's got to go and hop on another call?
No, this is Veronica Placencia. We're actually a client of USHC. And I just want to thank Gavin for such a great presentation and explanation. And I look forward to working with you again. With you and your team.
Love to hear your voice. Thank you.
Great. Thank you, Veronica. Are there any others? Okay. Well, thanks, everybody, for your time today. Gavin, great presentation. And if anybody is interested in a culture and well-being analysis, please feel free to reach out to Ashley or myself, and we would be more than happy to sit down with you and go through what a program like this can do for your organization. Thank you, everybody, and have an outstanding day.
Happy Wednesday. Thank you so much.
Thank you, everyone. Thank you, Gavin.